Okay, so now we're going to talk about gout. Here is a yucky foot with a very swollen great toe joint. And another name for gout, or what people call a very swollen toe joint, is called podagra. It's very, very painful. Gout comes on suddenly. It can affect large joints as well as small joints. The great toe here is the most common place for gout, but I've seen multiple patients with chronic joint issues in the ankle and the knee. So those are the most common places you're going to see it, but the great toe is the most common. It is the most common inflammatory arthritis in the United States and affects about 4% of us. It's attributed to westernized lifestyle. Most patients are obese and have hypertension and renal disease. But gout does not discriminate either, because I've seen people across the board with gout, although it does seem like there is that population that is obese, hypertension, sometimes alcohol, more excessive alcohol use. The westernized diet, lack of exercise does definitely is more correlated with that. Gout remains misdiagnosed, underdiagnosed, and undertreated commonly. I would say undertreated would be the most common thing that I've seen, because it is very, very painful, and these people really, you need to be more aggressive with the treatment. So how are you going to make a diagnosis? To go back to the symptoms, the patient does present with sudden onset, pain, swelling, redness, and warmth to the specific joint. It doesn't have to be bilateral. It could just be a great toe. It could be a right ankle or a left ankle. So it's usually what happens. So it's been a gold standard to do a aspiration of the fluid and look under the microscope. That's going to tell you whether you have uric acid crystals. Gout is uric acid crystals get junked up in the joint, and it can destroy the joint over time, which is we'll talk about in a little bit. So you can do the crystals, but now reality says a lot of times we don't do joint aspirations, or we don't have time, etc. So how do you diagnose it? So you can do an ultrasound. It's not really going to show up on an x-ray. Ultrasound is better than an x-ray, but you really need to go by the common presentation. Red, hot, swollen, the most common. So I'm going to click on this and show you this table. So you can go to this also. This is how we exclude it or include it. You get a point for each one. If you're male sex, previous arthritis attack, if the onset was sudden within a day, you get a half a point. Erythema, first MTP joint, hypertension, or greater than 1 cardiovascular disease, you get a point. And if your serum uric acid is greater than 5.88, I'm not sure who came up with the 88, something with research. So if you have less than 4 points or equal to, 95% do not have gout, and you consider an alternate diagnosis. Insufficient basis, consider arthrocentesis or careful follow-up. Between 5 and 7, greater than 8, 85% have gout. All right. Diagnostic criteria, which is what I just showed you. And just because a uric acid is normal does not mean the patient does not have gout. So repeating a uric acid level 2 to 3 weeks after flare-up to determine a baseline is really helpful. If you have a normal uric acid level, but then in 2 to 3 weeks it is down even lower, maybe they do have gout, but their uric acid level just did not rise in the bloodstream. And not all people with hyperuricemia or high uric acid have gout either. So those are just things to keep in consideration. How do we treat it? It has 3 principles: the treatment of acute attacks, prevention, and treatment of the elevated uric acid. So when the attack comes on, we give them medication. Then we may want to give them something to prevent it, especially if they're having more flares. And then we want to make sure that uric acid gets more down to normal, because then they're more apt to having joint damage. Oh, I think I did that. Okay, so this is an algorithm that shows, we're just going to talk about acute gout treatment right now. If they have an acute gout flare, this means do not stop Uloric or your allopurinol therapy. So if they're on preventative already, you don't stop it. You start the flare therapy immediately. What if they have advanced kidney disease or coronary artery disease? You don't want to give them NSAIDs. And you want to caution giving colchicine in chronic kidney disease. If they're already on a medication that are inhibitors of the CYP3/4A pathway, then you have to avoid or use caution with colchicine. So these are some treatment options. You can give the colchicine. You really should give it within 36 hours. You can do the intra-articular steroids for those that learn how to do that. You can give them prednisone, and you can give them NSAIDs. And if you give them NSAIDs, you really should consider giving them a proton pump inhibitor while they're on that, because you don't want them to get an ulcer. So I don't like writing a lot on slides, but I do feel like this is good information. These are the glucocorticoid regimens that you can do. You will see prednisone prescriptions written 100 different ways, but these are just these are the recommendations, though, given per the guidelines. So you can give 30 to 35 milligrams daily for 5 days. You should taper. You can give a Medrol dose pack instead. If 1 or 2 joints are involved, especially larger joints, then you can consider doing the intra-articular corticosteroids. And then I always already talked about this. NSAIDs, naproxen, indomethacin. Indomethacin was always the gold standard to give. It's not the best on the stomach. It still can be given. Combination therapy with 2 different classes should be initiated in the case of a severe attack or greater than 4 joints. So you can put them on indomethacin as well as give them a Medrol dose pack. So typically NSAIDs are given at the full dose for the first 3 days of the acute attack, and then you lower the dose over 4 to 7 days, and you tailor it to how they're responding to it. Prednisone you can give as a first-line agent if they have contraindications to use of NSAIDs. So basically you kind of have freedom to choose, do I want prednisone, do I want to give them an NSAID, or do I want to give them colchicine? You have to look at the individual person and see, do they have chronic kidney disease, and go from there to decide, or cardiovascular disease, or other medications that they're on. And again, the proton pump inhibitor may be needed. Colchicine is a very old medication, and they used to take this high dose every hour until they had diarrhea, and then realized that why would you want to go through misery like that by taking that much and getting diarrhea. So what we do now is you take 1.2 milligrams followed by another dose of 0.6 in an hour. After 12 hours, the 0.6, you can give it once or twice a day until the flare resolves. You want to give it for at least 36 hours of an acute attack. Many patients keep this on hand. They also keep the other medications on hand. So whether you do the NSAIDs or have a Medrol dose pack on hand, if they have gout flare-ups, it's always good that they have that at home so they can start it right away. How are you going to monitor whether the acute attack has gotten better? Well, you're going to monitor symptoms. Is the pain better? You're going to get a uric acid level and follow up with that to make sure that it's going down. So how do we treat chronic flare-ups? So I highlighted the green because these are really the most important. 2 or more attacks a year, palpable tophi. And as you saw the picture of the foot, that is tophi. Like you can get the lumps. And even if you look up tophi on Google Images, you can see tophi that's very pronounced on the different joints. Tophi confirmed on radiography, stage 2 or greater chronic kidney disease, or history of urolithiasis, then that warrants treatment for chronic gout. Also, you can give the urate lowering therapy in patients who have had gout at less than years of 40, because you don't want them to have joint damage. They have a higher prevalence of that because they're younger and you have a lot longer to live. You don't want joint damage. Uric acid levels higher than 8 or coexisting diseases. That's another reason why you want to put a patient on chronic treatment. So if urate lowering therapy is indicated, so we want to lower the uric acid, we can set a target uric acid level, which I've seen different guidelines, but usually it's around 4. You're going to start prophylactic treatment 1 week before the urate lowering therapy begins. You're going to start this agent, xanthine oxidase inhibitor it's called, or Probenecid, which we're going to talk about that. And if they're at target, then you're just going to continue the treatment. If they're not at target, then you either want to increase their medication to the maximum dose, or you want to possibly alternate what you're giving them, or consider Probenecid, which is another medication. We can't forget about lifestyle changes also. So this guideline says the target uric acid should be less than 6. For patients with tophi, should be less than 5. There's also ones that say 4. These are the xanthine oxidase inhibitors, allopurinol or Uloric. Uloric is taken once a day. Allopurinol is taken once a day also. They're basically the same thing. Uloric is the newest one that came out, which has a less effect on renal function, but allopurinol is really hard on the kidneys, so you must monitor the renal function. Also with the liver panel and CBC periodically. You want to check uric acid every 4 weeks until they're at goal. Then you'll check it every 6 months. If they have normal renal function, you're going to start them at 100 milligrams a day, and you're going to increase every 4 weeks by 100 until you're at the 300 milligrams. Some people have gone to 400 milligrams, but usually the max is 300 milligrams. If they have stage 4 renal disease, you start by taking 50 milligrams daily. A common error in gout management is to stop the dosing increase at 300 milligrams, even if the target serum urate level has not been achieved. So like I said, if it's not been achieved, you can go up to 400 milligrams. Although if you look in the drug books, most of them say 300 milligrams, so people are nervous about increasing it, which is why I've rarely ever seen someone on allopurinol higher than 300 milligrams. And we are nervous because of kidney issues. Some people can have an allopurinol hypersensitivity reaction. It can occur within 60 days. It's rare. Renal issues and thiazide diuretics can increase the risk of having this hypersensitivity reaction. Also, Korean descent with stage 3 chronic kidney disease needs genetic testing before they would even start allopurinol. And I've never ran into that. And 20% develop a rash while taking amoxicillin and allopurinol. There's another option of Probenecid. It's usually been given for under excretors, because there's over excretors, you're making too much uric acid, or you have under excretors, you're just not making enough you're not able to expel out or urinate out uric acid, so you're keeping it intact in your body, and then it ends up going into the joints. It's not prescribed too much, but as you can see on the algorithm, it is an option, although allopurinol or Uloric is your first line for chronic treatment. There are some other alternative treatments. Losartan can be used as, which is a angiotensin receptor blocker. I don't see it used very often, but it's here. Beta blockers. can help with an increased gout risk. And fenofibrate can lower the uric acid on average by 1.5 milligrams, which was quite significant. Weight loss, organ meat, red meat, seafood, anything with a high purine content, shellfish, anchovies, sardines. This is why most people don't eat a lot of the anchovies, sardines, organ meats, but you do see people drink a lot of alcohol, particularly beer, fructose-containing drinks, and soft drinks often increase uric acid levels. Diet drinks don't. Dairy proteins can lower uric acid levels, and coffee consumption also can reduce uric acid and the risk of gout. And there's some research out there that says to eat cherries too. So here's an approach to resistant gout. I'm not going to read all of these, but I wanted you to have this just to know that there are a lot of people out there with resistant gout. No matter what you do, you can't get that uric acid down at all. This is when you are, making sure that there are uric acid crystals where you're doing aspiration, or you're looking at their medications. What if they're on a loop diuretic or thiazide diuretic? You want to take them off of that. You want to make sure that you are promptly treating, you are acutely treating these patients. They have that medication on hand at home. Or you're adding another medication if needed. And involve rheumatology to manage care for patients with complex issues. If they have kidney disease, transplant, you're not sure, or it keeps coming back and it's not getting better, you send them to rheumatology. So that's it about gout. This is just ending the whole slide series in general. Rheumatologic diseases, when do we refer? Early referral is really important. I put a general guideline here. It's quite lengthy, but it is the general updated guideline when to refer. But number one, if you're not sure what's going on, refer. If you get basic labs and something's abnormal and you want to go further, either contact rheumatology and ask them what they want you to do, or refer. If you have any abnormal labs, such as the elevated SED rate CRP and ANA positive rheumatoid factor, that's an automatic referral. Anti-CCP antibody refer, that's automatic referral because you're thinking, okay, this patient probably has rheumatoid arthritis. Again, you're coupling this with their symptoms. And if unsure and you've excluded other differential diagnoses, refer. I hate to say refer. You don't refer very often, but there are times when you need to, and you need to reach out to your colleagues. All right, and if you want to look up any of the references, but I do suggest any of the links that I put in, the entire slide set, there are some fantastic articles, and there's a couple videos I put in there which will help you. All right, it was a pleasure, and you guys take care.